So today I am going to discuss the organophosphorus poisoning. So before discussing it in detail, first we should know about organophosphate. So organophosphate, it is widely used as pesticides or insecticides. It is absorbed from skin, gut and bronchial mucosa, which ultimately accumulates within the neuromuscular junction. Organophosphorus poisoning, it leads to overactivity of parasympathetic nervous system. So it is very important. Phosphorus poisoning lead to overactivity of parasympathetic system. But how? Now let's talk about the mechanism of action. It is presynaptic neuron and it is postsynaptic neuron. So as we know that in presynaptic neuron there is vesicles. Vesicles contain the neurotransmitter in the form of acetylcholine. Once the action potential reach, so this acetylcholine, it shifts from presynaptic neuron and to synaptic cleft, and it binds to the postsynaptic neuronal receptors. There are certain specialized receptor which is present over the membrane of postsynaptic neuron. This acetylcholine, it binds to the receptors on the postsynaptic neuron, and it ultimately lead to increased activity of parasympathetic nervous system. So when the acetylcholine bind to the special receptors on the postsynaptic neuron, so it lead to overactivity of parasympathetic nervous system. Now in order to depress the overstimulation of parasympathetic activity, we have a specific enzymes present on the postsynaptic neuron. In the membrane of postsynaptic neuron, we have a specialized type of enzymes. And these enzymes are called as, yes, acetylcholine esterase. Now these enzymes are called as acetylcholine esterase enzyme. Now what is the significance of acetylcholine esterase? This acetylcholine esterase, it degrades the acetylcholine, decrease the overstimulation of parasympathetic nervous system. So this is the normal mechanism. But actually what happens in organophosphorus poisoning? In case of organophosphorus poisoning, the organophosphate molecule, it binds to the acetylcholine esterases. Organophosphate molecule, it binds to the acetylcholine esterase and it blocks the acetylcholine esterase. Once the organophosphate, it binds to the acetylcholine esterase, so it blocks the action of acetylcholine esterase. As a result of that, the acetylcholine, it is not degraded acetylcholine. So increased level of acetylcholine lead to the increased parasympathetic activity. So this is how in organophosphorus poisoning there is increased level of parasympathetic activity. The clinical features of this patient. The clinical features of this patient is closely related to increased parasympathetic activity. All the features which is related to increased level of parasympathetic activity, the patient will be likely presented with with certain features. For that we have a simple trick for it, that is dumbbells. While every single alphabets will correspond to the one of the feature of organophosphorus poisoning. While D stand for the diarrhea and U stand for urination, M stand for meiosis, B stand for bradycardia and bronchospasm, right? So B stand for bradycardia and bronchospasm, E stand for emesis, while L stand for lethargy or severe lacrimation, while S stands for the salivation. First approach is ABC protocol. First, you have to maintain the airway, breathing, and circulation of patient. The second step is that is known as decontamination. Since the organophosphorus poisoning can be observed through the transcutaneous route, so if a patient comes with a skin exposure, then you have to wash the skin with soapy water. So if there is skin exposure, so first of all, what you should do, you have to wash the skin with soapy water. Wash within 2 hours of acute poisoning. And activated charcoal play a very less role in case of organophosphorus poisoning. Similarly, the induced emesis role, it is not proven so much. So activated charcoal and induced emesis have not so significant role. So what are the antidotal treatment? In the antidotal treatment, we have a different options. The most important and the most common antidote for the organophosphorus poisoning, that is atropine. So atropine is the best and first antidote for the organophosphorus poisoning. The dose for atropine is 0.6 to 2 mg IV. So the dose for the atropine is 0.6 to 2 mg, and it is given repeatedly for every 30 minutes till the atropine target is achieved. Is atropine target? So atropine targets consist of certain important 5 points: heart rate more than 80, BP more than 90, and in the chest there is no bronchospasm. In chest there will no bronchospasm. And the fourth is there is dry cough, pupil not pinpoint, pupil not pinpoint. So I repeat, what are atropine targets? Atropine target consists of 5 points. The first is heart rate is more than 80, BP is more than 90, while in the chest there will be no bronchospasm, there will be dry axilla, and the pupil is not pinpoint. The first three is the mandatory for atropine targets, right? So it's important. Now, if atropine toxicity occur, so what we should do? If atropine toxicity occur, then what we should do? When the atropine toxicity occur, then we have to stop atropine and we have to restart the atropine at infusion at a very low dose till the toxicity symptoms disappear. And what are those atropine toxicities? Yes, that is delirium and absent bowel sounds, right? So it's important. So what is the second antidotal treatment? So the second antidotal treatment is enzymes. Enzymes is basically acetylcholinesterase reactivators. Enzymes are acetylcholinesterase reactivators. So it is not so much helpful in case of organophosphorus poisoning as compared to atropine. But as per WHO protocol, the dose for the enzyme is, that is 30 mg per kg is loading dose. Most important point regarding enzyme is that enzymes is related with certain important side effects. And what is those side effects? Yes, the most serious side effects of enzymes is hepatotoxicity, right? So it is the main side effect of oxime, especially in obidaxime. Third antidotal treatment is magnesium sulfate. It is the ligand gated calcium channel, inhibit the NMDA. It inhibits the NMDA receptor. Also, the alpha 2 clonidine and fresh frozen plasma can be used as a antidotal treatment.